The social progress imperative and myself personally have had the great pleasure of working with Kieron and his team, Robert, Anna, and Alessandra, at Guy's and St. Thomas's Foundation a couple of years ago to develop something unique and remarkable. The first ever health-focused social progress index. And we're delighted Kieron is with us today to share their insights for what works in improving health outcomes. Kieron will start with a presentation, we'll then have a conversation, and there will be an opportunity for everyone to ask questions. Please welcome Kieron Boyle, the Chief Executive, Guy St. Thomas's Foundation.
Thank you. Thank you.
Kieron, over to you.
Brill. Well, firstly, it's such a pleasure to be here. And can I say thank you? I feel like I've learned so much over the past few days, including from Curtis yesterday, which is that a CEO should start any presentation with some numbers. I heard that ATB, you've been a purpose-driven organisation for 84 years. Well, Guys and St. Thomas has been a purpose-driven organisation for about 500 years, so it's not competition, but... I'd like to talk about what works in improving health. I feel that we've heard so much of that already over the past few days. I'll share a few examples from the work that we do at the Foundation, and in particular through our philanthropic arm that's called Impact on Urban Health. And what we do at Impact on Urban Health is we try and find very practical solutions to how you make cities healthier places for everyone. Now, I could give you a million examples of the work that we're doing, but I've heard from Petra that I'm not allowed to do that. So I will encourage you to check out our website at the end of all of this. I've heard from my wife that the website's better than sets. Read into that what you will. So, we spent quite... I'll share it at the end. I'll share it at the end. What? Yeah. I don't know, I was just thinking that was a very bad idea. Great. So, I mean, take it back a level. We've spent a lot of the past 2 days, quite rightly, talking about COVID. But of course, one of the most important realizations about COVID is that in many ways it's nothing new. Not just because we've had previous pandemics, but that too. But in fact, the patterns of COVID are happening around us all the time. So if we look at the virus, If you were financially insecure, if you travelled to work on public transport, if you lived in overcrowded housing, if you didn't have much say over your working conditions, you were much more at risk from the virus. So it wasn't a kind of a great equaliser. In fact, it was the opposite of that. It was a virus that targeted people who were poorer, minoritized communities, people already at the sharp end of health. But the whole point is that you can say exactly the same about a whole host of health issues. The same is true of obesity, the same is true of mental health, the same is true of long-term health conditions. And if you were to look at the mortality rates, for example, of, say, something like air pollution last year killed many more people than COVID has ever. So these patterns are happening around us all the time. But it goes deeper than that. So we know that COVID has had a huge economic impact, but avoidable health conditions also have a huge economic impact happening around us. So if we could improve health overall, we could add $12 trillion to the global economy. And let's take it to the UK. In the UK, about 2/3 of the years lost to ill health are in our working population. If you could tackle that, you would save about £300 billion a year, not in healthcare costs, but just kind of in productivity gains. That's more than we spend on our National Health Service. So it's broadly to say that these numbers really, really matter. And what's going on here? Well, it's what we've been discussing the past few days. It's about these wider determinants of health. It's about the air we breathe, the food we eat, where we live. It's about things like our income, our race, our ethnicity, our digital inclusion. And these areas are becoming increasingly, as we know, increasingly unequal. And so that means that our health is becoming increasingly unequal as well. So in places like the US and UK and others, life expectancy is stalling and starting to reverse, which is quite an extraordinary thing when you think about it. So this would encourage you to think, well, why aren't we doing more about it? This feels pretty urgent. Why aren't we doing more about it? And I think there are 3 reasons that we're not doing more about these issues. So the first of those reasons is that we take too narrow a view of health. We think it's about healthcare. It's actually about something much broader than that. But we also look at health mostly as a cost rather than an asset. So you try and reduce the cost, but you invest in an asset. The second reason is that, unfortunately, we have a sort of complexity inertia. So we kind of look at these social determinants of health and it feels a bit overwhelming. It feels like you need to change everything at once, so where do you start? And the third reason is that I think we're a bit defeatist. We look at these health issues and just assume that they're normal or that they kind of just the natural run of things, and they're anything but that. So it's important to tackle those things, and that's why it's been so great to work with the social progress imperative. Because really what you need to be able to do is do what the SPI does, which is find a way of looking at issues more holistically, find a way of targeting so you can get going, and then finally find ways that you can point to where progress is occurring and explain to others that, okay, right, we can get there too. So I'm going to give some practical examples of how we're using the Social Progress Index, or the Urban Health Index that we developed, to really get into these health issues. To do that, let me just say a few words about impact on urban health. So what do? We work in London. We work in 2 boroughs of London called Lambeth and Southwark. We've got a population of about 600,000 people. It's an incredibly diverse area. Pretty much anything cool that comes out of the UK comes out of these two boroughs. And I can be quoted on that. They're also incredibly diverse. They're one of the most cosmopolitan areas anywhere in the world. About every other person comes from an ethnic minority background. And they're also very unequal. So we have in the UK, in Lambeth and Southwark, some of the richest areas in the UK and also some of the poorest areas in the UK right next to each other. And so what that means is that these areas are essentially microcosms of trends that are happening in cities around the world. So what we do at Impact on Urban Health is essentially try and understand, well, how do these things play out? And they play out in all sorts of ways. And I'll come back to this later, but 2 neighbourhoods in the area, about a mile apart, takes 7 minutes to get between Tulse Hill and Herne Hill on a bus. There is a 17-year healthy life expectancy difference. There's a 10-year life expectancy difference for women there. So that is essentially the difference between meeting your grandchildren or not. So it really matters that we should do things about this. So if I were to kind of describe our work, which is about finding very practical solutions, if I'd give it a tagline, I'd call it precision population health. So what does that mean? Well, the work's very targeted. So essentially we try and pull together lots of different types of data, quantitative data, qualitative data, to really get under the skin of an issue. It's very open-minded. So essentially what we try and do is bring more people into tackling health issues than often see their role in it. It's experimental. We try stuff, see what happens, we test, we learn, we iterate, and we go again. And finally, it's sustainable, which is, I think, a critical part of this. Sustainable in the sense that we try and find others that we can scale to work with. Often it's by working with really large organisations who have the capacity to scale things themselves. Now, I'm very aware that that spells the word TOES, which is a terrible acronym. I'm just hoping it's so terrible that you might remember it. But anyway, so let me give some kind of practical examples of what this really means. So targeted, pulling lots of different types of data together. We looked at 2 neighbourhoods in the areas, and we used some clever maths to look at 2 neighbourhoods that were most similar on 40 characteristics, but most dissimilar on levels of childhood obesity, which is one of our areas of focus. And then we asked lots of people to go look around and see what was the difference between these 2 neighbourhoods. And essentially, looking at the food environments, in one of these neighbourhoods, Peckham Rye, that 65% of the shops displayed fresh produce, only 23% did in the other neighbourhood, which was Camberwell Green. And we go speak to the shopkeepers and ask what's going on there. And it looks like rents are actually that little bit higher in Camberwell Green than they are in Peckham, but enough higher that shopkeepers don't want to have perishable products. Now, you can actually go have a really practical conversation with the local council about business rates for those shops there. So you can kind of be very targeted with different types of data. Secondly, you can bring new people into this world who don't necessarily see their role. So people might have heard of the idea of social prescribing. It's when a doctor, instead of prescribing a pill, will prescribe somebody a walk around the park. Well, we've worked with doctors to prescribe debt advice because there's a reciprocal relationship between financial health and ill health. Once your finances get out of control, your health gets out of control. And likewise. And so we worked in a variety of communities that where we knew people were most likely to have financial ill health, prescribing debt advice, but the whole thing was paid for by housing associations and utilities firms because it's in their interests for their customers to have good debt advice so they get paid back. The work's experimental. We ran the world's biggest ever experiment into behavioural nudges in supermarkets, around 200 supermarket stores, around healthy produce. So you get rid of the buy one, get one free on soft drinks, and you put it on carrots instead. You swap out really unhealthy biscuits for slightly less unhealthy biscuits. And it turned out that this had real kind of population level effects. So the supermarkets basically sold more fruit and veg, less crappy stuff. But we were able to look at the till receipts to understand the impact on store profitability. And actually quite a few of the supermarkets ended up making money through these healthier nudges. So now they're scaling them without us having to do anything about it. And finally, I guess that brings us on to the point of sustainability. On our work on air pollution, in cities now, most air pollution is less and less to do with traffic. And it's more and more to do with how buildings are built and demolished. So we're working in the construction industry to understand ways in which you can build buildings in a way that improves health. If you do this well, the construction industry will carry on and do it as long as it's financially sustainable. So that's kind of just to give you an example of of how you can use these data-led approaches in quite practical ways. So let me move very, very quickly onto the Urban Health Index and just give two practical examples of how we've used it. So the Urban Health Index is the social progress index where we've taken certain measures and really, really targeted it towards health. And I've just pulled out here Tulse Hill and Herne Hill because those were the two areas that we saw the 17-year healthy life expectancy difference between. So what's going on between those two areas? Well, as we look at the data, we see a couple of different things. So we see that there are real differences between on educational attainment. There are real differences on access to outdoor space. There are real differences on average download speed between these two areas. And that last one has got us really interested. So we're actually running in Tulse Hill an experiment at the moment where we're looking at what happens if you give free community Wi-Fi to people. What impact does it have on their health? Because we know, in fact, there are lots of practical ways in which to get access to lots of things that keep you healthy, you need to have good digital access. But also what the Urban Health Index has helped us do is helped us move beyond just looking at income and the relationship of income and health, although that's important. So give an example here of two other neighbourhoods, Nunhead and Borough. They've got the same average income, these two areas. They have utterly different health outcomes. And as we look at the data behind, well, why might that be? It seems that the biggest difference between these two areas is around how engaged communities are, or that kind of that community engagement piece. So now we're doing work to understand, well, why is there so much more community infrastructure in one of these areas versus others? That's, again, a conversation that you can have with businesses, you can have with the council, you can have with civic society organisations as well. So I'm going to draw to a close there. But just to say that if I've left you with anything, I think it's that, hopefully, that health really matters. And as we've been talking about lots of things, I'd really encourage us all to think that health underpins a lot of the progress that we have to see. But secondly, it's a collective endeavour. We need many more people involved in creating health than currently see their role in it. And third is that actually there's loads of stuff that we could practically get going with. We've heard a lot of it over the past 2 days, and hopefully you've heard a few more examples there. I just want to give you a sense of how we're actually using the Urban Health Index in a very practical way. Thank you.
Thank you very much, Kieron. It's absolutely fascinating what you're doing and how you have been using the index. In light with our theme, truth and trust, you've actually already pointed out some truths that perhaps you weren't looking at before, that the index helped you uncover, looking at internet speeds.
Yeah.
I'm assuming that's something that you haven't considered before. Could be.
Not at all, not at all. And I think that's where we've really found the value of the tool. It's encouraged us just to be investigative, to be curious about things. And also it's enabled us to have that curiosity conversation with other people as well, to say, well, that we don't know what's going on here, let's go ask some questions and find out. When I say we don't know what's going on here, I should qualify that, because the whole thing about once you start getting down to this neighbourhood level data is that people in those neighbourhoods know this. You know, people on Tulse Hill know that they've got crappy Wi-Fi. They know that there's lots of things going on in their lives that make it harder to make healthier choices. So I think some part of this is it actually made it easier for those of us who are, for example, on the philanthropy side or in community services, to actually start to get a better sense of that at scale.
How about trust? Do you feel the exercise, the process, the product helped you in any way to build trust with your audience, with your partners?
It's shown us some fascinating things about trust. So we found that the index has got this incredible predictive power as well. So the index is able to predict better than any other index that we've come across whether people have had a COVID vaccination or not. And then as we look at kind of what seems to sit behind that, the strongest factor seems to be voter turnout. And I guess voter turnout tells you something about trust in a system. And certainly when we do work with communities and community researchers, something that really comes through from there is that there's often real levels of mistrust in the system as well. But for whatever reason, I think sometimes some people find it easier to see it in the data. Some people find it easier to hear people talking about it. When you can add these two things together, it becomes very powerful.
And if you were to choose one, the most significant learning or contribution of the index, what would that be for you, for your work?
For us, it's all about targeting. It's all about targeting. So you've seen the model. The model is essentially to try and really get under the skin of an issue, work out where you get started. And I've spent my career working in public policy, and honestly, a lot of the time, it's totally random. I mean, utterly random where we work, or who we work with, or why we're working with them. And I think what the index does is makes explicit often what is implicit. Helps you think about, well, why are you going to get started there? And then you can have a discussion about it as well. So it's really the targeting for us. Wonderful,
thank you. I'm sure there are loads of questions, including the very anticipated one on the website, in the room. So, anyone? Can we have the mic, if there is a mic, or do I have the only mic? That can be, yes?
Hello, everyone. I am Chet Matchett at ATB. So one of my questions for you, so when we dove into the SPI index in Alberta, big opportunity for us is access to information and communication. And so we've partnered with a company to bring access to internet in a rural location. And turns out that this rural location also had the highest unvaccinated rates in Alberta. And so there was an interesting correlation. And so correlation obviously doesn't always mean causation. But I am curious from the research and the investigation that you've done, if you've seen any correlation and causation between access to internet speeds, and rates of vaccinations for the populace.
Causation, no. And I don't think we can get there with the index. Correlation, yes, something very similar. Now, probably what's going on there, if you were to really push me in big cities, is really that you're talking about levels of income, levels of historic investment in a place. And those places that have been under-invested in, I wouldn't be surprised that the people living there don't feel as much security, as much trust in statutory systems or in the healthcare system. And that is probably the biggest thing that impacts upon COVID vaccination rates, certainly in places like the UK. So that's kind of what we've found. But I mean, just to broaden out that story, it is important on these things to really get the messaging right. So when COVID hit in the UK, the messaging being shared by our national government was protect the NHS, save lives, protect our National Health Service, save lives. But through things like the Urban Health Index, through our community research, we were hearing that communities don't feel protected by the NHS. So why would they protect something that they don't feel protects them? So we're able to work with government actually to get slightly more sophisticated messaging going out. So this stuff really, really matters in terms of things, for example, like driving up vaccine understanding and vaccine take-up.
Good morning, Jonathan Perkins with TEDx Calgary. But my question comes from that sense of strategic doing that Roselle mentioned yesterday, which is all about getting rapid collaboration and action on particular issues. And I'm fascinated with the rapid targeting system that the data set helps you to do. In the cases where, for example, you identified we could have a difference in health outcomes if we helped shopkeepers with their rents so they could do that type of thing, how quickly did that help you get the representative group of involved stakeholders on the same page and taking a relatively quick win step to potentially have a very significant long-term outcome?
Really good question. It's not always quick, is the honest answer. I think it enables us to hone in quite quickly. So I don't feel there's very much wasted time. We're able to hone in quite quickly. But really, it feels like it's like footsteps in the snow. Essentially, what we're doing is we're building and building and building as we go, and able to pull in different types of data that people can draw from. What we find, so let's use kind of the shopkeepers piece as well, is that it also enables you to put data in front of people who haven't seen data like that before. So if you were to, we find in our work with shopkeepers or is that often your convenience store, the person who runs it, is a really important person in the local community. They're thought of very highly in the local community. So if you can kind of start talking to them about, well, wait a second, you really care about your local community, but your shop is not helping the local community, but here are some things that you can do that would help. They're the biggest advocates, the biggest drivers for that change as well. But that data had never really been put in front of them. So that's the very practical way in which we start to build up momentum, I guess. So it's much more about momentum than speed.
Well, if there are no more questions, I will look forward to receiving the website link. And thank you very much, Kieron, for a very fascinating discussion and presentation, and for all the great work that you do with your team.
Thank you.
Because at SPI, we never know where our partners take the index. And as we always say, and I think this was actually mentioned yesterday, the index is just the beginning. It's the action that happens once the index is done. So thank you for all that work.
Thank you.